So we're going to get started with the webinar. We are lucky enough to have Annette Newman here to talk to us about the prolonged care of a burn patient in a non-burn facility following a mass casualty incident. Annette coordinates burn prevention and education in a 5-state region and works closely with EMS, healthcare facilities, and coalitions, schools, and community work groups. She has over 28 years of burn ICU experience. Annette is involved with state and national burn disaster planning and is a member of the Utah Healthcare Emergency Response Team and UT1 Disaster Medical Assistance Team. She's also the Western Region Burn Disaster Consortium co-coordinator. So I can absolutely assure you she has lots of experience, and I'm sure she has lots of knowledge to share with us on this topic. Thank you, Annette, for being here. I'm going to turn the mic to you.
Hi, folks. How are you? I think most importantly, I was unable to vote, and I want you all to know what I had for lunch, which I'm having for lunch, which is tilapia. I'm in the MST zone, so we haven't eaten yet, but that's what I'm about to eat after I get off this. Anyway, I am thrilled to be sharing my passion with all of you, and I definitely want to acknowledge all of those who assisted with this project, as it was a team that put this together. So I want to acknowledge those folks. I have a disclosure slide, obviously, and I don't have anything to disclose except a desire to ensure when a burn disaster occurs, we are as ready as we can be, because it doesn't take many burn patients to overwhelm the system, I'm sure, as you all know. And in the top right, I pulled some data from the NFPA 2017 fire report, which is pretty impressive. As you can see, the US firefighters responded to an incredible number of fires in 2017. 21 of those were listed as catastrophic, which means they had multiple casualties. And if we remember, 2017 also brought some historic California wildfires. They killed 44 people. And with that urban wildland interface, that's becoming more and more relative to our practice. And unfortunately, 2018 did not get any better. So with that said, let's look at some objectives. My objectives are that you guys will be able to describe what burn disaster crisis standards of care are, or BDCSC as we call them there. That you'll understand the role of the emergency manager as it relates to burn disaster crisis standards of care. You already know your role, but as it relates to burn disaster. And then you'll also be able to identify that the project is relevant to your practice and to your business continuity plans. And some of you may already know the early information that I will share, because it's about crisis standards of care, which I thought was a really good place to start. And as many of you know, this represents a paradigm shift in how we care for patients, and the shift is pretty difficult to accomplish in a fair and effective manner, as we must always train and work under normal conditions. So when we're forced to move into crisis care due to a disaster, we're basically asking providers to take on complex decision making that they have likely never practiced. We're also asking them to make guesses at current supply levels of resources and the level of demand for care by patients that may not even have shown up yet, all in this chaotic and very fluid situation. So it's obviously not realistic to expect anyone to effectively make that paradigm shift without some planning and practice, which is why we're talking about this. The other important information that you, I'm sure, already have is that the Institute of Medicine has published some really great guidance for the establishment of crisis standards of care. And as this table shows, there's this mismatch between supply and demand, which affects first responders as well as those in the hospital setting as first receivers. And these crisis standards are on the far end of the spectrum, the right side, if you will, of this slide. And there's a absolutely clear lack of staff, of stuff, and of space to care for patients in a normal fashion, and life-saving interventions such as critical care resources may be withheld. But on the left side, we have the conventional care model, which is how our healthcare systems usually operate under normal circumstances, and we can deliver a normal standard of care. But the middle zone, which is particularly relevant, as we'll talk about in the next slide, or contingency care represents this stage along the supply-demand continuum during which the healthcare system is stressed beyond normal operating conditions. But there are still strategies that we can utilize to stretch our capacity to provide functional equivalent levels of care, meaning that surgeries are delayed, caregivers have greater patient responsibilities, but we're still able to provide a pretty normal level of care to our patients, and more importantly, that the patients who would ordinarily live still live. And this is particularly important in our case as about 4 weeks ago now. So the University of Utah Burn Center is a 15-bed unit. And about 4 weeks ago, we got hit with 9 big burns in a 24-hour period. And we had 15 critical patients on the unit, most of which were intubated, very big burns, and 17 patients that were housed off the floor. So we were in contingency mode. That stressed our internal system. We didn't have enough staff. Every member of the management team, including myself, dropped everything and went out to the floor to care for patients. We had shortages of supplies. We had to move 17 of our patients to a different space. And it necessitated it necessitated change in the way we delivered care. Now that change wasn't crisis standards of care, but it was an alteration nonetheless. And a really important lesson to us that it doesn't always take a huge event. It can be a culmination of smaller incidents within a short time frame that also makes a difference. Now, each of you are involved as emergency managers or emergency preparedness folks in whatever capacity, and you've all probably inherited or conducted your own hazard and vulnerability analysis to identify your priority threats. And in Utah, one of our biggest threats is an earthquake, and as the Wasatch Fault is still the most active and hazardous fault in our region, as you see there, the death toll and the injury toll is pretty substantial. The information I placed in red is predicted. The information in black I threw in as probable. However, you can see that the University Hospital and the Primary Children's Hospital are both on a fault line, and were an event to occur, our state, our actual catchment area, which is usually 5 states, would be in big trouble because the specialty burn and the specialty ped center would be potentially no longer available. And had an earthquake occurred 4 weeks ago, during the time period we were already in contingency mode, we probably couldn't have taken any patients. We and would also have had to have moved 32 patients to other centers depending on the stability of our hospital, and those centers initially could have been non-burn centers. So why is this applicable to practice? Well, your role as an emergency management person is to ensure your facility remains in a state of contingency as long as possible. And as history has identified, it doesn't take many burn patients to overwhelm a facility. In addition, if non-burn center hospitals are asked to care for these patients for extended periods, that causes additional burdens as this already surpasses normal standards, even with resources. But I'm really actually preaching to the choir because you probably already know this. So what's the big deal? Well, burn mass casualty incidents are rare. This is a picture of our strike team vigilantly manning the 2018 Hill Air Force Base show. It's a relatively slow day, as you can see, although I did save a hemorrhaging woman that weekend by providing 2 tampons, but that was probably the limit to the medical care I gave out that weekend. The fact is, though, that we can fall asleep waiting for the next big burn event, and then bam, a FedEx crashes into a school bus, there's a bomb at the local football game, a refinery explodes, and we're called to action, but we lack the muscle memory required. And that is what is most applicable to you. Because when a mass event occurs, chances are it won't be right next to a burn center. And even if it is, they can't all come to us. We've seen historically that despite the infrequency of significant burn disasters, a burn mass casualty incident can significantly overwhelm local resources and exceed the capacity of the closest local burn center to provide care. Patients will need to be cared for initially at non-burn facilities that may be called on to render immediate critical interventions and prolong care until transfer to a burn center is possible. In fact, the 2017 to 2022 HPP directive specifies up to 96 hours. Now, this initial non-traditional distribution of patients may address the burn bed deficit, but it will not address the discrepancy in knowledge and expertise usually provided by burn center clinicians. The medical management by non-burn healthcare professionals, many of which will have limited amounts of knowledge and expertise in burn care, poses unique challenges. However, many of my mentors stated that all disasters are local and so are the solutions, and you as an emergency management person can address those solutions. And so we identify a gap, and that's what this project's about. And that gap is knowledge. And we know that initial care given significantly impacts long-term outcomes of burn patients. So in order to decrease morbidity and mortality, there needs to be an aggregation of essential evidence-based clinical information to inform decision-making for 96 hours, which is our directive, by community hospital and trauma center clinicians practicing in a facility without a burn center who may receive burn patients during a mass casualty incident. And hence the birth of this project, which was deemed to be the Western Region's Burn Disaster Consortium's top priority in 2016. And we'll talk a little bit more about that consortia towards the end of the presentation if you guys are not familiar with that, and the consortia within your local regions. So let's chat a little bit about the project. We gathered a team. And this team was important because in order to align with best practice recommendations by Devereaux and his team in a 2014 CHEST consensus statement, we needed to include pertinent local, state, tribal, military, regional, national, federal, and international stakeholders. So we gathered this diverse team, which started with about 41 folks, and then at project end, we were left with 34 people who stuck this out to the end. And they were assembled from 14 states in 2 countries, and this was an incredible aggregation of folks who were tasked with gathering data specific to a post-burn disaster environment. So in order for this to be evidence-based, it was really necessary to use existing approved state, national, and international standards of care recommendations to guide that content. And the 10 on the right side of your screen were selected as they provided recommendations for normal burn care delivery in a resource-scarce environment. They were the most current burn practice guidelines, or they adhered to core concepts from the ABLS course. And in addition, the curriculum was further informed by the identification of 12 critical topics. These were selected based on reoccurrence throughout those 10 evidence-based guidelines which were selected for this work. And they were also selected because of the significance of potential complications. Also, in order to identify applicable disaster content and care phases, we needed to review, or at least we felt like we needed to review, and this was a task in and of itself, we needed to look at all past burn disasters. And this led to a screening of over 3,500 articles, texts, chapters. We pulled everything that was ever written and published about burn disasters. And these were screened by 2 reviewers. We used Covidence, and 303 of them were assessed for full text eligibility. And a rationale for the final literature selection was as follows, because a burn mass casualty incident, according to Kearns and his team from articles in 2013, occurs when the number of burn injuries exceeds available resources and ability of the local burn center to provide optimal care. And this obviously would be situation and location dependent. And for purposes of this project, we used literature that reported on 3 or more patients as our mass event trigger, recognizing that curriculum would be for non-burn facilities, many of which may be rural critical access hospitals. And these critical access hospitals could easily be overwhelmed with 3 large burn patients. And so we ended up with 93 texts that were included in this. The literature also, interestingly enough, allowed us to identify what we thought was correct anyway, but we were able to positively identify 4 timelines or phases of care, which were repeated throughout these texts. These then became the individual e-learning modules, and it was pretty cool to see them definitively identified in the disaster data. And you can see these 4 modules are initial assessment and management, 0 to 48 hours, 48 to 96 hours, and then the final module, which was transfer and transport. Now, the HPP directive specified care for 96 hours, and so we combined that literature for specific information and identified 68 burn-specific procedures, interventions, or considerations post-disaster that were mentioned in one or more of the texts, and we addressed all of these in the 4 modules. The data also contributed to the module goal and the 22 objectives that came out of that work. And now, the other thing to remember is that, of course, the education is not fully comprehensive. Holy cow, we would be talking about it for weeks, but it addresses the critical information necessary to save lives. And I placed a picture of the Superdome here. I was lucky enough to be able to go to a conference in which I was able to visit it, and it reminded me that we learned many lessons from Katrina, and there are probably a few listening that have read 5 Days at Memorial, and that book had a profound effect on me. And it also reminded me that when we are challenged with making difficult decisions in a chaotic environment, use of evidence to support those decisions can be very helpful. And so we were very mindful as a team to keep those lessons learned and to try to keep down the amount of information that the modules contained. So this is my favorite part. In order to ensure optimal care can be delivered despite the constraints of a large-scale incident, the curriculum includes 3 tiered options for a fluctuating resource environment. And these tiers are listed as essential, better, and best. And I can't take credit for this. This is a concept that I found on a military site called Prolonged Care, in which tiers were labeled as good, better, and best, but we changed that to essential. And essential care is life-saving care that needed to be provided to all patients that meet treatment criteria in a disaster. And all these essential care items were approved by tribal representatives from really super rural clinics as being able to be performed in the most resource-limited facilities, such as those without means to intubate, to administer IV fluid, et cetera. And I just want to say that input by these tribal folks was crucial to this project, and I'm so grateful for their assistance. And in addition, care recommendations suggested in the essential, better, and best segments, if you look at them collectively, they're best practice, and their use does not need to be confined to a mass burn event. We also recognized that there needed to be a grab-and-go version for providers that would be a fast review, and we title these QRS, so quick reference sheets. And we know that time is of the essence. If we hear about an event, sometimes we may not have had an opportunity to go into anything. And so for providers that had not, these are easily downloadable from the web platform, and they can be placed in a reference binder prior to the event. But again, they are a fast grab-and-go reference and also are good for regular day and list important considerations. And one of the other important things that we added here was oral rehydration, which became increasingly more relevant with IV shortages after the hurricanes in Puerto Rico, et cetera. And we have evidence-based triage recommendations for the provision of care, or in some cases, limited care. And that's the chart on the bottom right that looks at the probability of survival of a patient using their age and total body surface area as a guide. And this can be really helpful when deciding on allocation of resources, and it's evidence-based from data gleaned from the National Burn Repository. And this is data pulled from everyday care. And we can see that those patients in red or orange have a high probability of survival, over 90% to be precise. Those in yellow have over 50% chance of survival. Those in blue, less than 50% chance of survival. And those in black, less than 10% chance of survival, dependent upon their injury. So this data, again, is really helpful, especially for you as emergency managers, as it can assist providers make super difficult decisions based on everyday evidence to conserve or reallocate resources that may be needed by others with a greater chance of survival if a facility needed to implement crisis standards of care. So the question would be, do I use these 50 liters of fluid on a patient that is in that black area, or do I use these 50 liters of fluid for 10 patients in this yellow area? So again, supported by evidence pulled from our data bank, our burn repository. So now, obviously, we wanted to see if this education made a difference to those who reviewed it, and hallelujah, it did. I just pulled some data from those who've already taken the pre and post test, and whilst there were several that failed the pre-test, they all passed the post test, which I guess is good. So hopefully that information is helpful, and we also included an evaluation, and there's a web address that all of this is housed on at the bottom of the page in the right-hand corner. The other thing that is really important is that the content, again, needed to be web-based in order to facilitate access by healthcare providers. And it includes ongoing process improvement methodologies, which is also stated by Devereaux as being important, and it included analytics to ensure that information was relevant and that folks used it. So I just pulled some data from it last week, and so far we've actually had more hits from burn center providers, which is interesting. And some of those came from Hawaii with the volcano issues back there. But the demographic component here is particularly relevant. As we know, a critical access hospital requires 25 or fewer beds. So we're actually able to observe user demographics and view participants that go into the website here. So this is our disbursement mechanism. We actually talked about disbursement the entire project, but these were some of the educational sheets that we used, just again, fast reference. I mentioned it at each education session I teach, as do others, and I'm delighted to be sharing it with you right now. So again, why is this relevant to you as emergency preparedness professionals? Well, when we pulled the historical data from all of the data sets that we reviewed, and the articles and the publications and the book chapters, etc., we found that 3 or more patients admitted to hospitals from the same burn event in the last 18 years have already exceeded the previous 60 years. That's incredibly significant. This is, however, most significant in rural critical access hospitals, which have limited resources and are often geographically distanced from the larger trauma facilities and burn centers, which means a smaller event can easily overwhelm resources and trigger local disaster plan activation. So that was pretty exciting, or I don't know whether exciting is the right word to use, but there was also really great data to see. So the clock is ticking. Are you ready? It's 12:23 a.m. on a Thursday morning, because that seems to be when all disasters happen. And you're fast asleep, and all of a sudden you get the call. And whatever your worst hazard and vulnerability involving fire is, it just happened. So how can these resources assist you now that you know they exist? Well, think about what your role is. You are charged with the implementation of preparedness strategies. Your goal is for your facility, for business purposes, to remain in a state of contingency for as long as possible. You have to coordinate with external entities, and you have to provide education and training to staff. So let's stick with the training and education for a few minutes. This is a huge undertaking, and we're all trying to do more with less resources and often wearing multiple hats. And these standardized recommendations do ensure that rational patient care practice can be delivered by healthcare professionals like yourselves, who may have limited amounts of knowledge and expertise in burn care. They're super easily downloadable. They're accessible on the website. And at last review, a few weeks ago, we had visitors on that website from all 50 states in the US and from 99 different countries. And these, most importantly, address not everything that is needed, but they address the key reasons burn patients die and how to save them. And there are also additional resources on that website in addition to this disaster-specific burn education that folks can join in with if they wish. And we do, every other month case studies. And so if folks want to get in and listen to real patients, real cases, then there's a tab for that on that site also. So let's take a look at the e-learning modules and how they might be helpful. So we again know that it's difficult for providers to engage in disaster preparedness initiatives, and that's just because of increasing time constraints and patient responsibilities. We just finished up 7 burn care mass casualty courses in our area, and one of the disciplines that was least attended, was least represented, was our physicians. And so we know that it's very difficult for them to get away from the bedside. And Devereaux also states it in his literature also. And these tiered recommendations are also applicable to all environments. And they provide this great 35,000 foot view. And so these modules can be assigned or proposed as a burn review, and as incentive, they also offer credit. We thought that might be helpful. They can also be used as a tracking mechanism for facilities who wish to see who has taken the education. So if you as an emergency manager want to go in and you want to see who has taken that education, then we can run a report for you. This can assist in the designation potentially as a burn surge facility in the future, as it provides documentation of training. And we are currently working toward that, and we'll talk a little bit more about that toward presentation end. But there are areas, there are regions, and your region may be one of them, that does have designated burn surge facilities. And so to be able to acknowledge that and communicate that in your states is really important. The other piece of this that I thought was particularly relevant is that we're actually able to view real time those who access the education, which allows us in a real disaster to see use. And so that's really important also. So our goal, your goal, is to remain in a state of contingency for as long as possible. So how is this helpful? So here's some examples from each module. As you can see, it's not rocket science. The goal of module 1 is to follow the standard principles of trauma management, but providers easily get distracted by the burn and they focus on things that are not important. And so pulling them back and assisting them is really an important piece of this. So you as emergency preparedness folks, as emergency managers, have limited supplies. So figuring out which patients really need a ventilator, who will potentially be okay without one, is really important. Knowing that there's a survivability matrix to guide decisions for care is important when resources are being depleted, and recognizing that prior so that resources can last for a longer period of time. Also recognizing that pain medication stores will be used quickly, and knowing some alternatives could be helpful. And these modules all contain an ethical component, which is an additional consideration for you as an emergency manager, which is also trying to conserve your staff, because oftentimes they're your most important resource. So if we look at module 2, which is one of my favorites, I noticed that a lot of this is one of my favorites. So, but the goal here is that the patient will receive successful resuscitation, and to know that a 40% burn in a 70-kilo male will require approximately like 11,000 mils of fluid in the first 24 hours, and that those fluid requirements continue till the wounds are closed is really important. And if you remember, after 9/11, the last person to be discharged was in the spring of the next year. So burn patients stay in the hospital for a long time. It's not unusual to have large burns stay for 8 to 9 months. And we usually say about a day per percent burn that people stay in. If they have an inhalation injury, it's even longer. And in a burn disaster, there will be enough IV cannulas, but in a large event, depending on restock capabilities, we might not have enough fluid. So resuscitation is huge. And knowing how to give appropriate amounts of fluid will be increasingly important so stores last longer. We also know that too much fluid causes additional complications such as compartment syndromes, pulmonary problems, and the increased need for intubation. So if you've already used your last ventilator, this is going to be problematic. So the correct amount of fluid is important, and conservation of that, and knowing alternates. And additionally, when crisis standards of care are implemented and there's no fluid or limited fluid, there's data to support oral resuscitation to those below 40%. 20% or 25% is the norm, but they can be oral resuscitation can be considered in those that are below 40%, because the GI tract can absorb up to 20 liters a day. And oral resuscitation guidelines are listed in the modules and on the QRS, the quick reference sheets. And hopefully we won't have to resort to this one, but proctoclysis, or rectal infusions with either tap water or normal saline, is another resuscitation option, and rates up to 400 mils an hour can be tolerated. Now, just so you know, this happens to also be a frat house initiation in colleges, with alcohol being used instead of water, as an interesting side note. So, so this module does give us fluid options, which will allow for the conservation of an essential resource in a burn disaster. It also talks about wound management strategies, and options for those include leaving the wounds open. And while this isn't optimal, there is data to support it, and it does allow for rational decision making when staffing is really tight or supplies are super limited. So if we move on to module 3, we see, wow, we're keeping patients for a long period of time, and again, this is our 96 hours, and avoiding complications is really crucial in this 48 to 96 hour period. And so this module assists in the identification of those patients who are not responding well, and also guides back to that survivability matrix, and gives some ethics in regards to that. So this is a really important module to look at also. And again, this is another one of my favorites, because it's an attempt to identify those who would be listed as expectant and those who would have first priority for transport to a burn center. This module can assist as you're called upon to assist with transporting patients after that 96-hour period, and it includes examples of a burn-specific handoff tool that can be utilized by receiving burn providers if and when patients from your facility after a burn incident are being transported. So let's take a look at our QRS, or our quick reference sheets, and we all know that time is precious, and lack of time is definitely one of the most quoted excuses I hear to not do something, including given by myself. So ultimately, the QRS should not be introduced for the first time in a chaotic environment, and could be a part of disaster reference materials. However, if there are 50 patients on their way to your to your emergency department, and you have 15 minutes to prepare, it's important to note that these may not be best utilized by the boots on the ground. For a provider to be given these, and we actually just demonstrated this in an exercise we just did, they don't want to be given another piece of paper that they've never seen before. So if these have not been seen by staff before, they may be best utilized by you as the emergency manager as you direct resources, and by supervisory staff who are overseeing care. They're not a part of the chart. They're a fast reference of that 35,000 foot view to review essentials in the management and treatment options when normal supplies are depleted, or when conservation is crucial. So let's say there is a burn mass casualty incident, and you do get the call at 2:24 a.m. and you are called upon to receive and stabilize those critical burn patients. And let's say they stay with you for 96 hours. They will, however, some at least, because not all of them most likely will be able to be moved, especially if it's a large event, but they'll need to be moved to a burn specialty center for skin grafting and rehabilitative care, et cetera. And we know that there's a plan in place for 10 or less people by the federal government. That's our special pathogens model. And there's a plan in place for hundreds to thousands. That's our NDMS model. But there's not really a clear plan as yet. It's been worked on for federal movement for large numbers of patients, burn patients, or PEDS patients, et cetera, needing movement, but not enough for a full NDMS activation. So the transport piece does remain to be seen, however, and I love the quote by Martin Luther King, who said, "I have a dream, not I have a plan." As that, I think, made all the difference to those who heard it. And in the burn center world, we do have a dream, and it's that all hospitals will be able to stabilize a critical burn patient for up to 96 hours, and we need you. This is a work in progress, and it will definitely take a village to be able to be prepared for this. So just before closing, because I know time, we've got maybe 10 minutes or whatever left prior to questions, but I did want to spend a few minutes reviewing the Burn Disaster Consortia. And this is specifically the Western Region Burn Disaster Consortia, as this project was initiated by that group, although others from other consortia joined us. But it is important for you to know that there are 123 self-identified burn centers in the United States with a bed total of less than 1,900. Many are located in metropolitan areas, leaving numerous patients without access to a burn specialty hospital. And the American Burn Association has divided the United States into 5 regions, with the Western region covering, as you see on that left side, the largest geographical area. This region is comprised of 13 states, which as of right now have 24 burn centers and a total burn bed count of 390. That's it for half of the US. There are 4 states without burn centers, and 13 of those 24 centers are in California. And whilst this is the Western region, all of you, as I talked about earlier, have a designated burn disaster coordinator who you can work with. You're all welcome to be a part of the Western region listserv and be updated and involved with projects. In fact, I'd love you to be on that listserv. And our next project will be to do specifically with patient movement. And this is one of the resources available in our coverage area, and this assists non-burn centers as, again, unfortunately, burn mass casualty incidents are not something we have often. So there's not really that muscle memory there, and it's important to note that this poster, it's actually what you're seeing is the top part of the poster, but the first step on this education piece is to notify an 866 24/7 on-call line, and that line goes directly to our state. We work really closely with our state partners, and when an incident such as wildland fires in California occur, or there's actually a nursing strike in California, which happened recently, or there are large national events, our burn coordination center can be activated by anyone within that region by calling that 866 state number. And then the state person on call answers it, then they forward that call to Kevin McCulley, our state HPP manager, or myself, or both of us, and together we can trigger a bed count, and we'll talk about that in a minute, to find out how many surge beds are available in the region. And again, all regions have this capacity. We, as a Western region, have all the numbers to everyone on a spreadsheet. We have their cell numbers, their office email, etc., and that's shared with anyone that's on that listserv. And then the tabs to this also include the ability to track patients by burn center. They also include air assets and trauma beds, etc. And all regions have data similar to this. This is how we house ours, and this is what our regional bed reporting sheet looks like, and this is what we report up to the federal government. And you can see that we have immediately open beds, and then we have surge beds, which are green, yellow, and red, and the capacity of each center to be able to take folks from each category. And this is a key coordination element for triage and transport in a small or a medium event. This definitely doesn't cover our large events. And I debated whether to put this in because it was just one more slide, and I knew we would be limited on time, but I did think it was important for you guys to have access to our surge criteria definitions. This is fluid, it's a work in motion, which does change, but this is what it is currently. And that then you can see that this is what we use as our surge criteria on those surge beds on that surge document. It doesn't, what's important to note here is that it does not include soft tissue injury, which was an issue with an exercise we just did recently in which patients had frostbite. And then also necrotizing fasciitis is another one that burn centers commonly take care of. And it also does not include radiation injury on here. So this is the data from 16 burn bed counts, but we've since done 20 since we pulled this data. And you can see that over a 4-year period, on average, there's only 127 open burn beds in our entire region, which is half of the US, and an estimated surge capability of 219 burn beds. And so if an incident occurred within our region, which generated more than 219 patients, we'd have to reach out to our other regional partners in the South and in the Midwest. And we have those on speed dial too, and we have plans, and they're no good if nobody reads them. But and this slide I know is difficult to read, but all of these resources are available and they're downloadable on that Crisis Standards of Care website that I mentioned earlier on. And we have plans for the first 24 and 96 hours. And the Western Region Plan also talks about collaboration with the EMS, public health, and local HPP, and matches federal recommendations, which we'll talk about in a minute. Now, obviously, I know some of you are thinking, well, what about advanced burn life support, and how does this interplay with all of that? Well, we collaborate very closely with a national organization, which is the American Burn Association, and the advanced burn life support is a part of that. And also our plans are. Our disaster plans are located on the American Burn Association website also. And these plans do differ a little, but you can see all of the different regions that are on there. And those plans work for those regions. And as you know, the ABA does oversee ABLS, and lots of you invest money into that course. And there is an acknowledged issue with ABLS, however, and that is that it addresses only initial management for the first 24 hours or less. So that's why this project was relevant and is important. And all burn team members on the project are American Burn Association members, and the project has also been approved by the Organization Delivery of Burn Care, which is a big committee from the American Burn Association and the disaster subcommittee as a part of that group. The other key coordination element for triage and transport in a massive burn event is coordination by all regions. And you can see this is a burn bed count that we did for the presidential inauguration in January 2017. And you can see that in all regions across the United States at the time of the inauguration, there was only 500 available open burn beds. So the potential for non-burn centers to be needed were a mass event to occur is substantial. This is an amazing site. I know many of you listening are probably really familiar with this, but we do pass all that information on to our federal partners. It all goes up the chain. And if you haven't been into Tracy, or Asper Tracy, and seen the mass burn event plan on that site, then please go into it. Our Western Region 96-hour plan does follow Tracy's recommendation, and that's tied very closely to that. But there's an amazing document that is stored on Asper Tracy under burn. So let's talk a little bit about forward movement as we come to close, and I take your questions. We have presented this project to the American Hospital Association. We have done a real-world trial on May 9th of this year, and that was with using the quick reference materials. We've done a couple of fairs and conferences, and then our hope upcoming is to have this published. But our end goal really is to prepare all hospitals that may receive burn patients to be burn surge facilities, and to potentially have burn surge facility designation to those folks. And just as a last slide, I love this quote. The horror of that moment, the king went on, I shall never forget. You will though, the Queen said, if you don't make a memorandum of it. And that's from Through the Looking Glass by Lewis Carroll. And I think it's really important to note that history is important, as it provides valuable lessons, which if noted and acted upon can improve the future and minimize vulnerabilities as disasters will continue to happen. We continue to learn new lessons, and Vegas was a great example of that with the distribution of patients from that event. And while this project is specific to mass burn incidents, it does have applicability to other specialties and can be utilized as a model for development of similar educational initiatives. So that is all I have to say, but I'm happy in this, I don't know, however long we've got left, to answer any of your questions.
Thank you, Annette. That was very eye-opening, and I, for one, can tell you that I am absolutely appreciative of the fact that you are doing all this work. I think it can benefit everyone and is benefiting many, many people. Everybody that's on, if you have questions, now's the time to go ahead and ask your questions. If you want to unmute your line and ask a question, feel free to do so. I don't think I have any restrictions on that. And if you would prefer to chat it in a chat box, feel free to do that as well. I think right now we're getting great presentation and amazing stuff. Thanks for all the work that you've done. Lots of appreciation to you, Annette, for everything that you're doing in this field. Any questions? Oh, Kelly Dickinson looks like raised hand, so go ahead.
Hi, Annette. This is Kelly. Great job as usual. I was wondering, have you taken a look at what the Strategic National Stockpile has in their resources in the way of the burn blast kits? And can you give any indication about how those may be used in disasters to help hospitals that are not necessarily supplied to take care of burn patients?
I love that you asked. Well, I love and I hate that you asked that question. Hi, Kelly. Yes and no. It's difficult. We do actually, as the American Burn Association, works really pretty closely with BARDA, and so we've had representation from BARDA that's talked about the Strategic National Stockpile and the burn blast kits that are in there. And I know that there's some realignment of resources, and we have actually been asked to give some input into what is contained in those kits. And so yes, we have looked at the SNS. I think the problem always remains in our conversations is how long will those kits take to be distributed to hospitals. I also know that there's a lot of talk about getting those kits out much earlier than they have been in the past, in the first 12 to 24 hours. And that's awesome. So I think that the kits will be really helpful. That first 24 hours will be crucial. And I also think that hospitals utilizing supplies that they normally have, because it's just like kind of this safety and security blanket, and the supplies are not necessarily specific to burns. They're used on all wounds. I think that's really important too. And so the SNS will be an important asset, but it will take a little time to get delivered to the areas that are in need of it. The other problem that we have faced with the SNS as a state is that if our worst case scenario goes down and we have an earthquake, then delivery of the SNS, particularly seen as we'll be on a ridge with Primary Children's, and there'll be a big divot between us and the rest of Salt Lake City, may be difficult unless our helicopter pad is still viable. So there's some challenges with delivery of those items too, but the SNS is very, very important. And yes, the American Burn Association does work with BARDA on some of that.
The other thing I've understood from hospitals too is they said that they really don't have the capability to take 33 pallets worth of stuff.
Right.
So breaking them down to a little bit smaller units than that. Thank you.
And oh, you're welcome. Thanks, Kelly. And I love all the changes that are going on in that right now. And I know that the DMAT teams are also taking a look at how the supplies would be distributed. We're a DMAT team to come into the state to assist and augment facilities that potentially need help in a disaster. So I love all of those changes that are going on at the federal level regarding SNS and the supply line, et cetera.
Thank you.
It's kind of a long-winded answer, wasn't it, Kelly? Sorry.
Thank you for the question and thank you for the answer. Any other questions while you're thinking about it? And if you're raising your hand, feel free to raise your hand. I just want to let you know that we find great presenters like Annette usually through word of mouth. So if you have somebody that you know is working on great projects from across the country that you think would be helpful in sharing with colleagues, please send them our way. We have a webinar presentation application on our website. It's under leadership opportunities under the members tab. So if there are people that you think would do a great job, direct them that way. We would love to hear. Let's see. Annette, can the callers join the quarterly burn webinars that you host? That's a question on the chat.
Oh, was that in regards to the case studies that are also online? Is that what that question is about?
ECHO webinars from Stephen.
Yes, they can. So anyone that requests access to the Crisis Standards of Care website, so you just Google crisisstandardsofcare.utah.edu and request access. I have to screen everybody that goes in because there's some public sensitive information and a lot of graphic images, so our HIPAA office is particular about that. But once you're in and you have a password, you have access to everything, all of the resources that are on that site. And one of the tabs on that site is the ECHO or ECHO or Extension for Community Healthcare Organizations, which allows us to relay specialty education to those that don't normally have access to it. And we also archive our sessions, but there's, I don't know, maybe 15 archived sessions going back to 2015 on care of the patient with a burn or soft tissue injury that can also be accessed for credit. And we talk more about, you know, patients with scald injuries, with frostbite, with purpura fulminans, with large burns, with inhalation burns, mass surge events, etc. And those are all on there. And yes, everything is accessible. We also have downloadable resources, and a lot of the resources that we have done in collaboration with the state have no logo on. That was really important to us because it's difficult for any hospital to put something with somebody else's logo on. And so our disaster resources and our care of the burn patient in the regular day guidelines, they're not logoed. There's only multiple joint logos, and that involves the state and federal grant information on the first page, but after that, they're not. And so those can also be downloaded. We also have wildland fire guidelines on there that are specific to those folks that are fighting wildland fires that get burn injured and what they can do, and information specific to the wildland environment. That is also, again, all downloadable from that site.
Can you please repeat the website?
Say that one more time, Christine.
Can you please repeat the website?
It is Crisis Standards of Care, all one word, .utah.edu. And I can't remember which slide had it on, but there was one of the slides, and I guess I should have put it on this last slide right here. My apologies, my bad.
Oh, sorry. I am trying to post this to everyone, but clearly I'm having some trouble. Oh, thank you, Steve. I think that that's all we have, and that's all we have time for. So thank you again, Annette, for spending your lunch hour with us. Now you can go back to eating your, I think you said tilapia, right?
Yeah. Much to the horror of my roommate, by the way.
It sounds delicious. Thank you for spending your time and sharing your knowledge and your experiences with us. We really appreciate it. And thank you all for attending. We'll see you next time.
Thank you. Thanks, everyone.